Good morning to all of you. Today's topic is subclinical frozen shoulder syndrome is a cause for many shoulder injuries which we normally neglect or we give it to physiotherapists to handle them. I'm going to show what is the frozen shoulder, how it is going to affect in our medical practice, and especially in an industrial setup, it's going to have a tremendous impact in managing their health. This is a very important aspect every medical professional should remember. We are still in evolution process. Almost it took 6 lakh years for human being to reach today's our capacity. We still have certain trouble because of evolution. Now let us review the effects of evolution on human body. Look at the quadrupeds, the four-legged animal species, which have horizontal spine, and the spine is completely supported by four legs, and they have very well defined skeletal structure for their survivability in nature. Now what happened slowly, these quadrupeds have become bipeds. That is the current human state. Spine became erect. This is the first change happened. Then shoulders became weak. Why? Because if you see the animal species, you can see their shoulder joints are very, very strong. If you see a tiger or a horse or any other animal, their forelegs are very, very strong when compared to their hind legs. But human beings, we have our lower limbs are very, very strong. Now the problem is the shoulder became very weak, yet it is very mobile, unstable, and very vulnerable to injury because it has a very wide range of motion in the joint. Look at the muscles. Quadriceps, gluteus became very strong, responsible for our erect posture. Then the other muscles like hamstrings, abdominal group of muscles, neck muscles, they became weak because when compared to quadrupeds, they have a lesser role in our body. And our pelvis has gone through many changes. It has tilted more anteriorly and our neck spine became very short. Why I am giving you this background on evolutionary aspect? Because this is a foundation for many painful syndromes. Most of the animals walk in front, very rarely walk back, but they do not walk sideways. That means flexion and extension, internal rotation. These are the pre-existing genetic mechanisms. Still we have these. But what have you acquired? We have acquired abduction and external rotation. These are the acquired mechanisms through our genetic evolutionary process. Remember, now most of the injuries or musculoskeletal disorders have a kind of a relationship with the abduction and external rotation. You see, these are primates, a shoulder joint, and slowly Homo sapiens, and this is almost a current human shoulder blade and the shoulder joint. Now there are a lot of changes took place. These are very strong for the movement of flexion and extension. But here the shoulder joint is very, very vulnerable for even abduction and external rotation. These are the acquired mechanisms, and that's why they are highly vulnerable for injury. If you see the anatomy of our shoulder joint, there are two movements which take place. One is a glenohumeral range of motion, and second is a scapular motion. 0 to 15 degrees of abduction of the shoulder joint, it is achieved by supraspinatus muscles. So if you are not able to lift your arm sideways, 0 to 15 degrees, straight away you can diagnose supraspinatus dysfunction or supraspinatus injury. Similarly, after 15 to 90 degrees, mostly it's a deltoid muscle, especially middle part of the deltoid, which is responsible for abduction up to 90 degrees. Now beyond 90 degrees, we rarely use in day-to-day activities, but we do use during industrial activities, exercises. 90 to 120 degrees is achieved by serratus anterior and trapezius. Now these are the genetically given range of motion to our shoulder joint. What is important is large number of population have some amount of tightness beyond 120 to 180 degrees in all age groups unless you're utilizing them. Why? Because this is basically achieved by a scapulothoracic rhythm. Scapulothoracic rhythm is related to so many muscles of the upper trunk, and this retains the shoulder joint intact. So complete abduction from 0 to 180 degrees can happen. This is in a normal, healthy person. But what is this frozen shoulder syndrome? In our day-to-day practice, even in industrial medical practice, occupational health practice, very commonly uttered diagnosis is frozen shoulder syndrome. We do have different names: periarthritis, adhesive capsulitis, shoulder contracture. All these refer to absence or decreased abduction of the shoulder joint. It may be a bilateral or it may be a single side. Now, there are lots of theories to explain, but unfortunately medical sciences didn't go much deeper into frozen shoulder syndrome, and it is normally handled by a physiotherapist or a physical therapist, chiropractor, many other people. Lot of mechanical causes create frozen shoulder syndrome. There are also causes idiopathic which are still not known why some people have frozen shoulder syndrome despite being very healthy. There are certain reasons for trapezius dysfunction, such as a neuropraxis, and there are theories of pathomechanics, the mechanism itself related to some pathology, and there are diseases which can cause frozen shoulder syndrome. Now let us see, the mechanical causes are very, very clear. Any injury, fall on an outstretched hand, or even a abduction injury, maybe in sports, all these ultimately lead to a kind of a supraspinatus injury or deltoid injury, leading to mechanical cause for the frozen shoulder. There are dislocations where there is a sudden impact of very high degree road traffic accidents or falls during extreme weightlifting competitions can have dislocations. Brachial plexus injury starting from childbirth to at any age, it can have a serious impact. Cervical spinal cord injury, these are all mechanical causes, definitely cause frozen shoulder syndrome. But there are so many non-mechanical causes. Still, we are not really 100% sure does really diabetes cause frozen shoulder syndrome, but it's very often we see frozen shoulder syndrome among many diabetic persons. Thyroid dysfunction, hypertriglyceridemia, cardiovascular accidents with upper extremity paresis, Parkinson's disease, all these are normally encountered with frozen shoulder syndrome. Now, diabetes being the most common disease, let us study the diabetes. Why frozen shoulder syndrome? As much as 38.6% I have noted in my practice, they are not completely diabetic persons, but they do have impaired glucose tolerance. They may likely to go into diabetes in future. All these people have early frozen shoulder syndrome. But established diabetic persons, 71.5% of them definitely adhesive capsulitis, and they do suffer from pain, radiating pains because of this. There are a lot of hypothetical theories: poor circulation, abnormal collagen repair because of the diabetes, early degenerative changes, platelet-derived growth factor from ischemic blood vessels, stimulation of local myofibroblast proliferation, microvascular disease, predisposition to infection. All these can cause frozen shoulder syndrome in established diabetic persons. What are the studies and observations, especially related to my practice and my colleagues? Let us go through this. Being a sports medicine doctor, having worked for more than 25 years in sports medicine, I have seen the transition of biomechanics in sports persons because of frozen shoulder syndrome. Now, if you see, frozen shoulder syndrome can change your day-to-day mechanics because of the pain. These are the yesteryear's great bowlers. They didn't have frozen shoulder syndrome. And they're all sports activities. They were very, very smooth. They didn't have any mechanical restrictions in during bowling and other game practices. But now see the next slide. You see Kapil Dev could release his ball at 12 o'clock position. That means almost 180 degrees of the shoulder without much impingement, without any pain. But 2 decades later, we have seen a lot of bowlers having abduction failure to a varying degrees, and these people are not able to bowl in 12 o'clock position, and they are able to bowl only in 10 o'clock and 9 o'clock and even 11 o'clock. Why? That means younger generations in many strata of people like frozen shoulder syndrome is seen today. You see frozen shoulder syndrome mild to moderate in many sports persons. Table tennis, badminton, tennis, cricket, athletics, shooting. You see here, the more number of people who are involved in playing indoor games, they have more amount of frozen shoulder syndrome, when relatively lesser frozen shoulder syndrome in tennis and cricket, and least in athletics, because there is something to do with outdoor exposure. Maybe vitamin D deficiency is one of the causes. So frozen shoulder syndrome does exist in large number of sports population. When it is seen in sports population, you can imagine non-sport population also might be suffering in quite large numbers. Shoulder dislocation and varying degrees of shoulder injuries approach me, both sports and non-sports people. When comparing the affected side to the non-affected side, that is a non-injured side of the shoulder joint, there is no big difference. That means before their injury, they may be having a pre-existing degree of shoulder joint stiffness, and that may be a predisposing factor. This is my hypothesis. Now what happened? I have studied large number, only 485 for these studies, males and also females in quite large numbers, as early as 8 years to 65 years of age, and many of them are active participants and also some of them non-sports participants. If you see this data, shoulder dislocations 23% and shoulder pain around 32%, diagnosed shoulder injuries like slap tears and labral tears 41%, and some kind of a tendon diseases because of the injury 10%. But the funniest part is, actually if you examine the other side of the shoulder, they also have a similar. There is no big significant difference between affected side, that is injured side, and non-injured side. This clearly signifies they already had some amount of pathology in their shoulder joints. That means before their injury itself, they already have a sufficient degree of tightness in the shoulder joint with respect to abduction. So there is some pathomechanics which is interfering in the daily biomechanics. I call it frozen shoulder syndrome, can affect from pathomechanics, converting into wrong biomechanics, and further he may get injured. See this diagram. This man has more than 120 degrees of abduction in the shoulder joint. This is a very important point to be noted, my dear colleagues. This person will not have any injury, neither at the shoulder joint, nor at the elbow, nor at the wrist. He escaped from injury during this fall, compared to person who has pre-existing shoulder tightness, that is a frozen shoulder syndrome, that is a partial degree of abduction failure at the shoulder joint. He is at very high risk at shoulder injury than elbow joint injury, or it could be injury at the wrist joint, varying degrees of musculoskeletal injuries. This is very surprising. So when shoulder joint is smooth, there won't be any hyperabduction forces obstructing the shoulder joint. But when there is already frozen, there could be a labral tear, slap tear, supraspinatus tendinosis. There are a variety of injuries can happen, including anterior dislocations. There could be a recurrent hill sac lesions at the shoulder joint, Bankert lesion, hill sac lesion, slap tears. All these are the cases routinely we operate in our practice, and 90% of them have external and lateral rotation, and mostly these are the anterior dislocations, and the mechanism of action is external rotation, lateral rotation, and abduction. During evolution, incomplete benefits we got from our genetically acquired characters. When there is any problem in the human body, acquired movements are restricted by the joints to enhance, to walk in front and back. That is most important for movement. Posterior dislocations are very, very less, only 4%. Inferior dislocations are very extremely rare, there is only 1%. This is another study of my own. This is a pain management study, still it's going on. I have already completed 9,000 change. All these people come to me with sciatica, radiating pains, multi-level disc disease, myalgia, arthralgia, and maybe some injuries. 79% of them have a varying degrees of frozen shoulder syndrome. That is very significant. That means large number of population is going through a transition of free shoulder abduction to frozen shoulder syndrome. Now there are theories to explain. First is theory of neuropraxis. You all aware neuropraxis means smaller injury to the outer fibers of the nerve. But frozen shoulder syndrome is hypothetically related to neuropraxis. What happens in a most common unergonomic sitting in many occupations, including IT professionals, doctors, almost 30% of the all jobs are today sitting, and they are unaware of exact ergonomics at workplace. We had large number of cases with straightening of the spine and foundation for neuropraxis at the cervical region. These are all the acquired postures. Not only ladies, gents also follow. There is no gender bias here. All these people cause tremendous strain on the cervical spine, can lead to neuropraxis. And what is the mechanism of neuropraxis? Extension of the head, putting the head forwards. And then there is a lateral flexion of the head. There is rotation to the opposite side. This is how we see. And this is how the lot of pressure onto the accessory nerve happens. And large number of occupations in industries, all of them have during their sitting postures, even their working postures, if they are unaware of ergonomics, they are all going to go into forward head posture with a upward gaze. Forward movement of the lower spine also puts center of gravity in front. So there is a tremendous pressure taking place here in this region, and that is where the 11th cranial nerve, the accessory nerve, and there is a kind of a very minimal impingement, or there could be a neuropraxis which is blamed from tethering force on the brainstem. So a neuropraxia or ischemia, prolonged gaze of forward head posture, there could be a kinking here of related blood vessels going into the skull, and also neuropraxis of 11th cranial nerve, that is an accessory nerve. Both can cause a kind of a paresis of trapezius and part of the deltoid, and that is how abduction may be failing in day-to-day activities. But my dear friends, I am talking only the tip of the iceberg. Now the frozen shoulder syndrome is a most neglected global pandemic of musculoskeletal disease with serious complication. It can have repetitive strain injury on neck causing disc bulges. It can have repetitive strain injury on the lower back, increasing risk for disc prolapse, thus lot of disc diseases. And it is not just a physiotherapist's responsibility, and it needs a very deeper understanding. So we need to look at very seriously. All these children had shoulder joints were completely frozen. But I said, why? Same thing I have observed in my practice. All my clients who come with the frozen shoulder syndrome, large number of them are not adhering to their staple diet. North Indians are eating South Indian diet. South Indians are eating North Indian diet. Influential diets, 63% and much more. It can cause subclinical malabsorption syndrome. The first thing affect your mobility. It could be osteoarthritis, it could be infectious diseases. First thing human complaints is I am not able to move. So there are so many people, like 43% are already suffering from malabsorption. 23% of them have lactose intolerance, Gluten intolerance can cause severe joint dysfunction, but it doesn't happen in one day. It can happen over the years. Remember, diet and frozen shoulder syndrome are very much related, very much connected. So going through a joint disease. Now, frozen shoulder syndrome doesn't leave you there. It normally goes into a very, very painful state of 3 to 8 months, almost 1 year. Imagine in a 1 year's time, a person is not given adequate management, he is going to eat a lot of NSAIDs and steroids, and he's going to ruin his constitution. These frozen conditions remain for a long time. In our day-to-day practice, we are not really examining abduction. Large number of people do recover, but it is very, very infrequent. Many of them with disability of frozen shoulder syndrome, permanent affair. And this changes all biomechanics of the body, and they have in turn different problems. What are the future directions of frozen shoulder syndrome? It can be a good predictor for early shoulder injury. If my abduction is not 120%, if I fall on outstretched hand, definitely I will have dislocation or supraspinatus injury or maybe rotator cuff injury. This is what we see in cricketers and many sports today. It is underestimated. Current medical management is insufficient, and we cannot leave it on only physiotherapists. It is a definite future challenge, and I thank you very much.